All right, so I'm going to just kind of give an introduction to endovascular interventional surgery, kind of the aka VIR, to Year of the Snake. So it's really becoming kind of started off as the West Coast, and now is really have a global mission, reaching out to for our North American colleagues in Canada, as well as Europe and Asia. So we're hoping to continue that trend. So when I went to med school down in near South Beach in Miami, my initial goal was to become a surgeon, maybe cardiac surgery, etc. But what happened was when I was on my surgical oncology rotation, these patients were very miserable. Extensively post-op courses every morning. They were just complaining of pain, inability to eat, and just quite frankly, just it was just sad to round on them in the morning. And then the oldest patient on my service was an 80-plus-year-old guy who had a Klatskin tumor, which is a bile duct cancer that caused him to be jaundiced and itching and pretty miserable. And he went to this interventional radiology area, which I not really didn't understand what that meant or what it was. But the long and short of it, they did some things with wires and catheters, open up the blockage, put in a stent, put a little band-aid on the exit site, and literally the next morning he was smiling, eating a full breakfast, and went home. And it was like nothing happened to likely the oldest guy on our service. So that's when I realized that the future surgery was minimally invasive medicine or minimally invasive surgery. And endovascular interventional specialists were in the forefront of it. So when I did my internship in Chicago, I really enjoyed seeing patients and did not want to give that component up. So where did this all begin? It began with this guy, the great Charles Theodore Daughter. So he's the father of endovascular. Oh, sorry, I think my slide changed. He's the father of endovascular interventional surgery. He had the construct and concept of surgery without a scalpel, developed the concept of thrombolysis, and countless other things, including stents. So when did he envision this process? It was in when he was invited by Joseph Resch at the Czechoslovakia Radiologic Congress in June of 1963. And he said, cardiac catheterization and angiographic techniques of the future. That was the title. But what he proposed is this, the concept of surgery without a scalpel. And he was such a visionary. He goes, hey, I think this angiographic catheter can be more than a tool for passive means for diagnostic observation, with imagination again become an important surgical instrument. In January 16th, 1964, the world of medicine changed forever when this lady, Laura Shaw, who was an 82-year-old with a heart failure and severe congestive heart failure, had peripheral artery disease and gangrene, okay, critical ischemia. She did not want an amputation. No, and she refused an amputation, and she was going to die. And daughter was the only person who was requested to see if he could do something with the technique called daughter, now called daughter, where he crossed it with a wire and used these Teflon dilators to open up blockage. And it worked. She lived for 2 more years, but she was able to leave the earth with both her feet. Pretty impressive. Now, in the US, like everything else, we're late to adapt. We were late to adapt to this technology. And the surgeons of the time didn't believe in it. It was like it was heresy to do this without cutting them open. So in fact, they would send a referral for pictures, angiography, but don't fix it. Well, daughter, being who he was, he's like, okay, I won't fix the SFA. You can do it end or, but he did fix the profunda. And the funny thing is the profunda stayed open, the SFA did not. Well, beyond just opening things, Joseph Roche, who was the Czechoslovakian physician who invited daughter to give the talk, was now his partner in the Oregon Health Science University in Portland. He did the first embolization of an upper GI bleed using autologous blood clot to the gastropleural artery in a patient who is cirrhotic. So we open vessels, we block vessels, and we kill tumors. We do so many things. We take care of strokes, PE, DVT, blockages in leg arteries, kidney arteries, intestinal arteries throughout the human body. We stop bleeding intestines, in GI tract, the brain, coughing up blood, nosebleeds, and trauma. And again, we kill tumors throughout the body. So we have a lot of innovation. In the 1970s, this guy, Cesar Gianturco, developed this coil with these Dacron fibers to stop bleeding, called an embolization coil. Guglielmi here, an Italian gentleman, and Fernando Vinuela, and Gary Duckweiler did the first intracranial coiling using this detachable coil mechanism. We've also become more and more involved in one of the leading causes of death in the worldwide cancer, and we've arguably become a fourth pillar, along with radiation therapists, surgeons, and medical oncologists. And this is a very early procedure done by Dr. Yamada on embolization of a liver cancer, HCC, using transarterial routes. So the blood vessels are our highway to do surgery from head to toe. Coronary angiography was inadvertently founded by this gentleman, Dr. Mason Sones, who was a pediatric cardiologist whose catheter inadvertently flipped into the coronary artery as they were doing picture taking of the aorta, and it showcased that it could be done. Well, Melvin Judkins, who's one of Daughter's first fellows, was asked to go over and learn the Sones technique where you did a brachial cut down to figure out what to do. And well, like all IRs and interventionalists, he's like, can I do it differently? And he formed these catheters, Judkins right, Judkins left, to allow it from a transfemoral route. So we, along with our cardiology colleagues, developed the SCI, the Society of Cardiovascular Angiographers and Interventionalists. And in fact, Judkins was the president-elect, the second president of that society. In the US, we did not adopt the techniques of Daughter, but in Europe, they did. This is Eberhard Zettler, a German radiologist, and Andreas Grunzig, an angiologist, who were listening intently to what Daughter was talking about. In fact, Grunzig in 1977 did a balloon angioplasty of the coronary artery using this special balloon that he developed and made in his kitchen, a Mylar balloon. Well, ballooning is great, but the vessel recoils or can dissect. So Julio Palmas developed this concept of a scaffold called the Palmas stent, which is now in the Smithsonian Institute to keep the vessel open. This great guy, Kurt Omplatz, who was in Minnesota, came from Europe, developed so many things where he fixed so many congenital heart defects with this devices that PFO and ASD occluders and VSD occluders. This is like a lasso, like a cowboy, where we use this to remove foreign bodies throughout the body, including from the heart. And he developed a concept of endourologic procedures. Again, really revolutionizing medicine on a day-to-day basis. Dr. Volodas, who's a Ukrainian surgeon, and Dr. Parodi was a surgeon from Argentina, developed the concept of repairing the abdominal aorta without making an incision from the subxiphoid process to pubic symphysis or retroperitoneal incisions. They would fix it with small incisions in the groin. And that's amazing. One in the 1980s, late 80s, one in the early 90s. But even medical students submitted patents for this even before all this. So the innovation can occur at any stage in your career, and so you can innovate right now as we speak. Again, tremendous amount of innovation occurred from Daughter to Judkins to Amplatz to Sheeran Turco to Dr. LaBerge, Katzen, Dake, Beninati, so many innovators. And I encourage you to look at the Canadian interventionalists who developed the liver bypass from the hepatic vein to the portal vein, bypassing the liver as a shunt. And there's so much continuity. There's so much technology moving the specialty forward, moving medicine forward from a device development standpoint, using lasers, rotational atherectomy, directional atherectomy, different types of stent grafts, different types of needles that enable us to freeze tumors throughout the human body. This is a kidney being frozen, a kidney cancer being frozen, preserving as much normal kidney as possible. And we're using more and more techniques throughout the human body to treat various conditions, including obesity, arthritis, sports medicine injuries, men's and women's health, neurointerventions, lymphatic, venous, arterial interventions. So much is going on. It's so rapidly expanding that it's hard for any individual to keep up. Now, one of the key things with this, as we move through all this technology, it's very important to understand this construct that Daughter said at the American College of Surgery meeting in 1968. My fellow angiographers prove unwilling or unable to accept or secure for patients the clinical responsibilities intended on angioplasty. They will become high-priced plumbers, facing forfeiture territorial rights based solely on picture-taking equipment others can obtain and skills still others can learn. So really the most important evolution of this specialty has been embracing outpatient longitudinal clinics and comprehensive patient care. And with that, we're really going to continue to expand our role in healthcare and in medicine, not only here, but worldwide. So original clinical VIR endovascular interventional surgeons really established in Alexandria, Virginia by this great guy, Barry Katzen, who we just came back from his meeting, the ISIT meeting in Miami. And he started doing AAAs in 1994. He started live cases, but truly he was a visionary because he adopted the concept of clinic from a radiologic standpoint and from an interventional standpoint. And really, this was one of his early publications in JACR. Tom McNamara, another guy who is also one of my mentors, reason I'm in LA, a true clinician, did his own wound care, admitted his own patients, accepted transfers, saw about 30 patients in the office a week. And this is kind of the model that we use to establish our current practice at Kaiser LAMC. These are some of the catheters he engineered, including the Craig McNamara catheter. And I had the luxury and pleasure of being between these two great giants, the great Barry Katzen, and when Dr. McNamara got an award at the ISET meeting a couple years ago, I was able to take this picture with them. So again, between two legends. Now, Katzen did this great talk at, yes, a Global Embolization Symposium in 2008, talking about the death of IO, can we learn from lessons of the past? The key slide was from this Eamon Hobbs presentation, who was the founder of Angiodynamics, where we go, hey, we're innovators, which is no question. We generate an idea, develop, there's a lifespan, then it starts to migrate out as lost procedures. And the question is, why is that? And one of the things you have to understand, especially referrals are never sustainable. Really, sustainability comes from direct referrals. Primary care physicians, patients, ER urgent cares, and hospitalists. And that's really what you want to grow. In the past, we would get it from a specialist or surgery to VIR. But really, now what we're seeing is more and more referrals directly from patients or from primary care to us. And I think we can always transfer to the next level and be gatekeepers of diseases. So the final part of this whole process of technician to clinician is really recruitment. We're recruiting a fundamentally different person, really a surgeon who is passionate about patient care, who has the stamina to handle these longer, more complex interventions that we're offering, and really transforming our training to include more ICU care, management of diabetes and hypertension, really good at history taking and physical exam skills and features. So the great Andreas Adam, and I hope some of our United Kingdom colleagues are joining the call, but was one who also influenced me from his daughter lecture. There was actually in Toronto, the Vini Vidi vanished. And what did that entail? Well, he said this core concept like, we're fishing from the wrong pond. Radiologists don't necessarily understand where VIR is going. It is surgery. And so perhaps that is a problem that we need to address. And those who are more focused on phlegnomastic and kind of skeletal dysplasias and the esoterica, we need to kind of change where we're going. So what does that entail? Change in recruitment and training, where the focus on WCVIS is on the patient and not the procedure. And so we developed a concept of dedicated interest groups focusing on surgical types for VIR who love operating, who love clinic, and understand the demanding lifestyle of the surgical specialties. Radiology teaches anatomy and pathology, but you really need to know physio and pharma and microbiology. You really need to learn head-to-toe anatomy and pathology, and that's where radiology shines in a very efficient fashion, but they don't learn how to do physical exam history, managing a patient, diabetes, hypertension. That is critical to being a good doctor. So they developed the construct in 2012 of an independent interventional specialty separate from radiology. And so now we have these dual boards in the US. And really, the focus is on the outpatient clinic, admitting your own patients, and doing formal consultations. These are a few of the patients that I've had the pleasure of being able to treat, including this young patient in his 20s who was locked in syndrome, couldn't walk, talk, or move because he had a posterior fossa vertebrobasilar thrombosis. I, along with my neurointerventional colleagues, were able to remove the clot and just retain TICI-3 perfusion. This is a patient who had abnormal uterine bleeding, excessive bleeding during her regular menstrual cycles, which really impacted her daily living and quality of life. We were able to treat this fibroid, and she went on to live a happy, healthy life. We do a lot of complex aortic repair, which again used to be open stem to stern. This is one of my patients with Burgers who smoked and unfortunately had these gangrenous digits. We did an inframalleolar below the ankle revascularization, doing a pedal loop, and she was able to save her leg, and now she's the biggest proponent of stopping smoking. One of my patients who couldn't walk because he had complete cable thrombosis, we used his veno-veno bypass, the perfusions through a pump, these large 26-French sheath, and we were able to remove all this thrombus. Another one of my patients with Takayasu, I treat episodically because she gets some kind of global hyperperfusion of the brain. You can see not seeing as much filling of the right. She's living on the single vessel, which we balloon angioplasty, improving perfusion and mentation. We've started doing these now, these off-the-shelf thoracoabdominal multi-branch endoprosthesis, where the technology continues to improve, enabling us to treat more and more difficult conditions and more challenging patients. And this is how we put more vessels in the celiac, SMA, and in the renals, and do multi-visceral stenting. and aortic repair. This is a patient we treated this year with Dr. Lamb and Dr. Bob, my colleagues, and it was the MSSA bacteremia in a patient who couldn't clear with severe tricuspid insufficiency. And this is after we removed this kind of bulky infective clot, and within 24 hours, she cleared her MSSA bacteremia. So for 2 years, it's important to learn the basics: anatomy, pathology, physiology, microbiology. Step one, study super hard, even though it doesn't necessarily count as a score. Learn heart, lung, liver, kidney, brain. Get very good foundation in surgery and IM. These are going to be critical. And fourth year matters. Make it count. 3 VIR sub-Is, vascular surgeries, surgical letters. Surgical internship is going to be critical. And remember, clinic is crucial. The current model of VIR training is inadequate. ICU, you need more and more of it, more and more clinic. This is Dr. Baden Harut doing some surgical debridement and revascularization and length. So you got to know diabetes, hypertension, all these other things, comprehensively manage your patients, and own them for life. Be the patient doctor, not the doctor's doctor. So the future of surgery is now: minimum invasive, maximum effective. Clinic is a cornerstone of success, and it's unethical to practice in any other way. Remember this: when you're in training, patients fight hard, so you need to train and fight even harder. Thank you.